pregnancy, implantation of the fertilized ovum outside the uterine cavity, fallopian tube, especially the ampullary region, is nearly 70%, followed by the isthmus is 12%, fimbriae is 11%, and the interstitial or the corneal region is 2 to 4%. Other locations like ovaries, cervix, abdomen, and the cesareans have. Risk factors like a prior ectopic pregnancy, pelvic inflammatory disease, PID, chlamydia, trachomatis, tubal surgery or the sterilization, assisted reproductive techniques, intrauterine device use, and the endometriosis, smoking, and the maternal age greater than 35 years. Clinical features like classic triad, amenorrhea, vaginal bleeding, spotting or the light bleeding, lower abdominal pain, other symptoms, shoulder pain, phrenic nerve irritation from the hemoperitoneum, dizziness, syncope due to the rupture and the hemorrhagic shock. Beta HCG. Serial beta HCG level should double every 48 hours in the normal pregnancy. Plateauing or the slow rising beta HCG suggests ectopic pregnancy. Threshold. Transvaginal ultrasound should detect an intrauterine pregnancy beta HCG greater than 1500 to 2000 mi discriminatory zone. Transvaginal ultrasound, absence of the intrauterine gestational sac with beta HCG greater than 2000 mi. Adnexal mass or the tubal ring sign, free fluid in the pouch of the ductless suggestive of the rupture. Choledosynthesis, rarely used, the presence of non-clotting blood in the pouch of the ductless suggests the rupture. Management. Expectant management only in the selected case where the beta HCG is low and declining and the patient is stable. Medical management like methotrexate, single dose or the multiple dose regimen. Indication: hemodynamically stable patient, no fetal cardiac activity, beta HCG lesser than 5000 mi and the ectopic mass is lesser than 3 to 4 cm. Surgical management: laparoscopic salpingostomy if tube preservation is possible. Laparoscopic salpingostomy if tube is severely damaged or ruptured. Emergency laparotomy is unstable patient with a ruptured ectopic pregnancy. Complications like rupture, life-threatening hemorrhage, infertility due to the tubal damage, increased risk of the future ectopic pregnancy. Ectopic pregnancy is implantation outside the uterine cavity. Most common in the fallopian tube, ampullary region is the most common. Risk factors include the PID, previous ectopic pregnancy, tubal surgery, IUD use, smoking, and the IVF. Classic triad, amenorrhea, vaginal bleeding, and the lower abdominal pain. Beta HCG levels that rise abnormally slow or the plateau suggests the ectopic pregnancy. TBA shows no intrauterine gestational sac despite beta HCG greater than 2000 mi. Methotrexate is used in the stable patients with a beta HCG lesser than 5000 mi and the ectopic mass is lesser than 3 to 4 cm. Laparoscopic salpingostomy if preferred if the tube is intact. Lampectomy if the tube is damaged. Ruptured ectopic pregnancy presents with the severe pain, hypertension, and the hemoperitoneum. Emergency laparotomy is needed for the unstable rupture ectopic pregnancy. Future ectopic risk increases after the one ectopic pregnancy.